Deja from Poland, when to intervene in mitral regurgitation.
If I only can find the presentation here. Oh, it's okay. Now, first I want to thank Sveto and Marko for inviting me, and it's a real pleasure to be here. Second, I have to acknowledge that we agreed with Marko that I will talk about secondary mitral, because I'm a secondary mitral surgery proponent. So it was a very nice introduction, I would say, because my bias is that I think it should be operated. And I was very unhappy to see what was developing recently. So obviously it's quite difficult to give all argument within 15 minutes, but I will try to raise some points about secondary mitral regurgitation and the way I see it. First, let me start with what we have in guidelines. And European guidelines, as you can clearly see, are all level C, so it's all the eminence rather than evidence-based medicine. And it's all only the severe mitral regurgitation in class 1, 2, and 2B. The class 1 and 2A is only for patients with option for revascularization. So if you have no option for revascularization, you're class 2B at best. And if your ejection fraction is below 30%, then there is no surgical option for you according to guidelines. So this means that we operate plenty of these patients off-label actually. And I just want to remind you some trials that easily show that this can be done and should be done. This is the ACORN trial, but I'm not going to talk about ACORN device now because it's all gone, although it was working, as you can see on these slides. But these were the patients who all had secondary mitral regurgitation due to dilated cardiomyopathy and the ejection fraction of around 20% and big ventricle. And they were randomized to either receive mitral valve surgery plus ACORN or without ACORN. So they all had mitral valve annuloplasty. And you can appreciate that the operations were done with a pretty elegant low mortality. And the ventricles improved significantly within 2 years with end-diastolic volume going down, even with mitral valve operation alone quite significantly, and the quality of life improving. Let me remind you this trial. This is the small study of 50 patients with dilated cardiomyopathy and severe mitral regurgitation, secondary mitral. They all underwent a rigid mitral annuloplasty with quite undersized ring of 24 or 26 size. And you can appreciate that after a month, they had a decrease of left ventricular and systolic volume quite significantly from 112 to 96 of index and the increase of ejection fraction. But importantly, if you look closer at these patients, you can actually divide them into so-called responders and non-responders. You had those who decreased their ventricle and those who did not respond and did not decrease their ventricle. And the authors found that the best cut-off value was the decrease of 8 milliliters per square meter. And if you divide these patients according to whether they managed to decrease the volume by this 8 milliliters per square meter, you'll find a huge difference in survival and the freedom from heart failure. What I'm trying to say, and the point I'm trying to make, is that just because you cannot discern these responders from non-responders before surgery, doesn't mean that you should postpone the surgery altogether. We shall probably try to find the way to discern those and not to get rid of the surgery altogether. Now, another point I wanted to make is that if you look at the guidelines that were produced 2017 and you look at the guidelines produced 2012, the only difference is that this point that was 2A, this was the operation in moderate ischemic mitral, is completely gone now. And it's gone because of this very study. This is called CTS-NET trial, moderate mitral regurgitation trial, that was powered for end-systolic volume reduction, and there was none in a randomized population of 150 versus 150 patients who had CABG without or with mitral valve annuloplasty. And there was no difference in survival, obviously. Slight improvement in activity status in those who had mitral valvoplasty. However, the authors of the guidelines completely ignored some other facts. This is another randomized trial. This is the RHYME trial that again randomized patients to CABG or CABG with mitral annuloplasty in moderate ischemic mitral. And you can see significant improvement in the ventricle in those who had mitral valvoplasty and not in those who had CABG alone. You have significant improvement in BNP levels. And what was the study primary endpoint, you have significant improvement in their exercise capacity as studied by ergospirometry. What was the difference between the two populations? If you look at the results of these two trials, you'll find that CABG alone treated majority of patients in the CTS-NET trial. So the mitral regurg disappeared in 70% of them just by doing CABG alone. So it was quite a specific population that was quite easily treated with CABG alone, when it happened only in 50% in RHYME trial. And the number of recurrent mitrals was slightly higher as well in the CTS-NET. Another thing which is important is that the patients started from completely different volumes of the ventricle. The CTS-NET trial patients started with the end-systolic volume index of around 60-55, while the patients in the RHYME trial started from the end-systolic volume closer to 80, and they decreased significantly. Now, this is completely against when they designed the trial, the decision was that they will recruit the patients with the volume of around 80 mils per square meter, which is the presumption close to what we've seen in the RHYME trial. And in fact, they ended recruiting much smaller ventricles with much better ejection fraction. Now, the authors of the guidelines, although did ignore completely our results from the STITCH trial, I had the privilege to look at this data, and we published them in 2012, showing the patients. Remember, STITCH was CABG versus medical therapy in a ischemic cardiomyopathy. And this is the survival of the medical cohort with the patients with moderate and severe mitral regurgitation, more moderate than severe actually. This is the survival if they had grafts only, and the mortality. And this is the mortality if they had mitral valve edit. And after statistical adjustment, we've shown significant survival benefit by adding mitral valvoplasty to grafts. Actually, we've seen the same in the so-called hypothesis 2, which was SVR versus SVR plus CABG, CABG versus CABG plus SVR. And again, if the patients had moderate or severe mitral regurgitation, adding mitral repair, which was left to the surgeon, improved survival dramatically. In fact, these patients, as you can see, had again much bigger ventricles and lower ejection fractions than in the CTS-NET trial. And if you look at the survival, these obviously are different patients' populations, because survival at 2 years is much better in the group from CTS-NET trial than it was in STITCH trial. Now, if you look at the guidelines again, we know that in the European guidelines, we have a different threshold, which is like 20 and 30 for, 30 volume and ERO of 20 square millimeters for secondary mitral regurgitation. And the American guidelines, even though they left the notion of moderate mitral regurgitation repair as class 2B indication, if you read the guidelines, they writing that they recommend changing the threshold back to 40, to not to operate on patients who are with a volume of 40. They say that the volume of 60 would be better, in understanding that this is better cutoff, not to be too, that this cutoff is more specific for mitral regurgitation, not to overdo the surgery. Now, if you think volumetrically now for a while, if you have a patient with a ventricle with 200 mils, an ejection fraction of 40, And then you expect him to have you will calculate the stroke volume will be like 80 milliliters. So if you expect this patient to have 60 mils of regurgitant volume, then you would finish with someone having a forward flow of 20 milliliters, and a cardiac output, even with 100 beats per minute, would be like, what? 2 liters per minute. Now, I was devastated by Mitra FR. It came as negative, you know. But then I've seen co-opt, and it gave me a true belief that somehow it can be done, that if you do something to secondary mitral regurgitation, you can improve survival. Now, even if you use MitraClip, which is not giving you perfect repair. Now, how to reconcile these two results? This is proposition given by Paul Grayburn, talking about proportionate and disproportionate mitral and coming back to regurgitant fraction, showing that to have the 50% regurgitant fraction, in different ventricles, you're talking about different volumes. So probably we need to go back to regurgitant fraction rather than the given volume. And he elegantly showed that Mitra FR is on the proportionate side, while co-opt is on the disproportionate side. The only trouble is, and this is not in the paper, I drew it myself, if you put it on a part with the volumes, they both on the disproportionate side. And another funny thing about it is that if you look at the end-diastolic volume of co-opt and the volume of the mitral regurg, you come to this calculation. These are patients with 200 mils of volume and ejection fraction of 30. If they truly had 60 milliliters of regurgitant fraction, they would have no forward flow at all. So something is wrong with the numbers in these trials. And something is wrong in our reasoning about mitral regurgitation, simply because we are miscalculating the volumes. So maybe we should use CMR more often rather than echo, and we would know what the exact situation with volumes is, and we would be more prone to make a proper decision. And the last point I wanted to make is the severe mitral regurgitation operation. While European guidelines are still recommending mitral repair, American guidelines are now for mitral valve replacement in these patients. And this is again due to CTSNet trial, the different one, 150 versus 150 severe mitral repair versus replace. And you see that there was no difference in left ventricular and systolic volume reduction with two types of surgery. And obviously no difference in survival. Interestingly though, you can note that this dark green bars are the patients with recurrence of mitral regurgitation. So the mitral valve repair produced at 2 years 40% or 50% of mitral regurgitation. Now, it's well-known phenomenon that actually mitral valve repair with annuloplasty in secondary mitral is producing a lot of repairs that is estimated of up to 50% at 3-5 years after surgery. At the same time, I had the privilege to present recently data at the AATS from Polish National Registry of Cardiac Surgery Procedures. This is the obligatory database for all the centers. We enter all the procedures there. And within 12 years, we identified almost 10,000, 9,500 patients with secondary mitral regurgitation who were operated. And you can see the survival of all cohort and propensity matched cohort showing the benefit of performing repair rather than replacement. And this is even with the assumption that the repair was not perfect and producing recurrence. You would expect these curves to cross at some stage. So, I don't know why, but repair worked better. If you look at the CTSNet trial a bit closer and you look at the patients who had a repair that worked, then in these patients, effective mitral valvoplasty produced a huge decrease in left ventricular volume. Obviously, you can argue that this is other way around, that these are the patients who had a reverse remodeling, and this is why they did not recur mitral insufficiency. That's possible. Now, what I would suggest, you need to think how you do your repair to make it more perfect. We know that there are some subvalvular methods. So one of them is papillary muscle sling. Another one which we prefer is the Crohn's procedure. This is papillary muscle sling showing in small trial that improves ventricle, and it is quite stable. But what I wanted to show again is the so-called Crohn's procedure or papillary muscle relocation. It's relatively simple. You take a Gore-Tex stitch, the one that you take for the artificial cords. You take one, which is this is the anterior papillary muscle, and both heads of it, and then you go forward beyond the cords towards the aortomitral curtain or the trigone. You do the same on the other side. This is the posterior papillary muscle head, and there will be an anterior head of the posterior papillary muscle in a minute. Sorry, I would like to move it forward, but I think it's impossible from here. And again, we go towards the trigone. Okay, now we put a ring in a more or less classical way. This measure 32, we always undersize it. This is a classic rigid ring. We always take a rigid one for secondary mitrals. You pass the Gore-Tex stitches through the ring in the places where they fit. And now after cutting off the cords, you are left with this Gore-Tex stitches. You fill the ventricle with water, and then under the water test, you tie them up to bring the valve up. It's probably not very well seen here. You'll see it on the other side. When tying and pushing, you bring the valve up until you see both leaflets appearing. Now you know that your tethering distance is no longer the limit. And this is the patient after the operation, and you can see that the valve is closing at the level of mitral valve annulus. Okay, this is the patient 2 years after the surgery. You may believe or not, this ventricle is 400 mils, and it's still competent, and this one is holding. Okay? Now, this is one of the meta-analyses showing that some subvalvular intervention may actually improve your result. Okay, so just let me conclude. The first thing is that severity of secondary mitral regurg in relation to the LV enlargement and dysfunction is still not very well understood. And the benefit of surgical treatment of secondary mitral regurgitation is bigger with more severe regurgitation, but as assessed by the regurgitant fraction. Secondly, use of CMR may improve our understanding of the role of secondary mitral regurg in LV failure, and correction of secondary mitral regurgitation improves symptoms and possibly survival in at least some patients. And subvalvular correction, papillary muscle relocation, from my point of view, should be used more frequently when mitral annuloplasty is performed when treating secondary mitral regurgitation. And this is my own kind of policy, which I'm going to argue works in my hands, but obviously I had no chance to show you all arguments for all the things I'm showing here. So I do add mitral repair to the patient, or to optimal medical therapy or CABG alone, if you have patient with more severe MR, patient with a larger left ventricle, patient with lower ejection fraction, with more dyspnea than angina, with less viable, this is against the guidelines, rather than more viable myocardium and less contractile reserve, with a patient who will have increase of MR on exertion, in patients with LV dysynchrony, in patients with larger mitral valve annulus, and in patients who are long time after MI. And obviously, I have had annuloplasty with papillary muscle relocation rather than mitral valve replacement. Thank you very much for your attention.
Thank you, Dr. Deja. Now have we have some discussion, comments from the auditorium?
I think that I loud. Okay, thank you very much. It's a very nice lecture. I must protect echocardiography. I agree that the 2D echo is not so precisely, a lot of problems are there, but today 3D echo give us opportunity maybe for proper making decision using 3D volume assessment, because we couldn't send on CMR every patient with a severe MR. Maybe it will be in the
Maybe
future.
once.
Maybe once, okay, I agree with this. But you know also that CMR can make mistake also. I'm not talking about the mitral insufficiency, but in a PR, there is a volume is not high and the fraction of PR is severe. So problems everywhere is possible in calculation. So I hope that in the future we will be closer to the CMR and agree about that. Can you comment something about 3D if you have
No,
experience your team about that?
yes, I agree that you have better estimation of volumes with the 3D. But generally speaking, if you look at the papers comparing CMR with echo, echo tends to underestimate the volume in comparison with CMR. And I'm not saying that this is always wrong. What I'm trying to say that I'm trying to find the reason for which, if you calculate what I just did, in many trials that were performed, because I can show you, I had no time, but I can show you on many of the trials that were performed on secondary mitral. In many situations, the calculations comes just impossible for the patient to be alive, because this forward flow would be like minimal. So something is wrong in the way we calculate and assess mitral valve, and I don't know, I believe it comes from a wrong estimation of volumes with the techniques we're using for
Who is the reason?
every day.
Techniques or a person who is doing that? Maybe the both of them?
Of dimensions. It's a more complex question because we are living in the 3D world, and we say that there is a fourth dimension, but we don't understand what is the fourth dimension. So, and we are behaving in the same way in a mitral valve. We are still looking the mitral valve as a two-dimensional structure, and we think there is a third dimension in the mitral valve, but we still do not understand. And on the other hand, we have all the data and all the failure of the mitral valve repair in secondary mitral insufficiency based on fixing a tri-dimensional problem by a two-dimensional solution, let's say reduction annuloplasty. And this is the problem. Once we take in mind, as our colleague demonstrated here with this, tri-dimensional suspension or whatsoever of the papillary muscles in this ischemic valve repair, we are going to understand that results would be much better in the way when we understand this problem in a proper dimension and treat it in a proper dimension.
But I must continue, sorry. Better than me knows that make a classification due to that the cardiac surgeon and cardiologist speaking the same language. And I feel that he was really good in that, and it was helpful that we are thinking and looking from the same way. Okay, new techniques, and give another opportunity. Personally, me, I was looking all operations, and for me it's helpful because I understand what you are doing there. I suggest to other colleagues to also go there and to see all these operations because it's helpful for a further assessment, but we must be on the same side.
I just wanted to say, without our cardiologists, our work on mitral valve would not be possible altogether. And without echo in theater, in OR, you can do nothing. What I'm trying to say is that maybe we are just wrong expecting 60 mils of MR on every patient to operate. And we need to judge this in relation to the ventricle size, to the forward flow, backward flow, probably come back to regurgitant fraction rather than the certain number. Thank you very much.
Thank you, Dr. Dea. The next lecture is Dr. Bartunek from Belgium with the insight of mitral clip procedure, challenges and future trends.